Yes, now we open the Q&A session. If there are any questions from the audience, and then please make it. And we have a couple of questions also from the. So please. No questions, so we read the question that has been sent. The drawback of the definition of Poseidon classification is based on number oocyte retrieved. Therefore, it is assumed that all follicles during oocyte retrieval yield exact number of same oocytes. It is usually, in clinical practice, that oocyte yield could be more or less according to the number of grown follicle, which depends on the experience of the operator or the status of empty follicle. So how the authors standardize this effect in all cases?
It is a good question, and this is one of the points where we have a discussion between those who use more the Ford and those who use the Foy. And of course, it depends on the ability of the operator to do the egg collection, but we say, okay, we take it for granted that they are good operating and by finding the eggs. The problem of empty follicle is actually not a big problem, because studies have shown that only about 2 to 3% is the probability to have an empty follicle. So looking at the large dimension of 30, 70, 50%, 2 or 3% will not make a difference. So I think this is not an issue, and it is still a good marker to see how your stimulation management is affecting the growth of follicles and reaching to mature oocytes.
Yes, Robert, and let me add that the empty follicle syndrome, it does not exist. It's only a problem of a question of problems during the final injector trigger of oocyte maturation. So when you have an empty follicle, so when you cannot retrieve a correct number of oocytes, this means that something went wrong in the last injection of agonist trigger or ACG trigger, or the patients made mistake or any other thing. So the empty follicle syndrome does not exist. All the follicles have an oocyte inside.
Yes, I agree, Filippo, and I would like just to comment rapidly. One thing is a general classification system, and one thing is the review of any single case. Let me give you an example. If you have looked to the Bologna criteria, one of the 3 criteria is 3 or less oocytes in the previous cycle. But in that case, we don't ask why 3 oocytes. It was an empty follicle. But it was a problem at the egg collection of ACG and whatever. One thing is reviewing the single case, because anything can happen. I think that, for instance, Ford and Foy are very useful when you summarize the result of your unit. In Italian Society for Fertility and Sterility, CIFES, we made an attempt to define KPIs also for ovarian stimulation and egg collection, because you have a lot of system for KPIs nowadays, from measure, but they are basically focused on lab procedures, standardization of procedure. But how can you understand if your stimulation triggering, timing, and egg collection is going in the same way, in the right way. And I think that FORT and FOI are very important, because if in your unit the FORT and FOI are below the expectation, it means that something wrong is going in the stimulation protocol, triggering, or egg collection. And the comparison between FORT and FOI is crucial, because if you have a low FORT, the problem is in the stimulation in general. If you have a good FORT but low FOI, the problem is at the triggering or in the system of aspiration. So I strongly suggest in your center to check any mount, or every second mount, every 3 mounts, the general FORT and FOI for understanding the process.
Speaking about the ovarian sensitivity, it could be better to think in the future to include the AMH and not the anti-follicular count in order to assess the ovarian sensitivity, taking into account the accuracy and the difference interobservator.
I am sorry, I apologize, but I am totally in disagreement. And let me tell you why. Because IMH is obviously useful for understanding how many follicles are probably in the ovary, for hypothesizing about timing, for counseling purpose. But one thing is to say the ovarian reserve is still good or whatever. One thing is to say how many follicles I have in that moment for that patient. I create my expectation on this, because it's a mystery the way the ovaries spend last follicles. You can have a patient with the lower anti-Mullerian hormone, but with the very active follicular waves at that moment, because it's probably spending follicles in a different way. So my expectation is on the number of follicles I can recruit in a given moment, hic et nunc, as Latin say it.
I think that we have some questions.
So, if we go deeper in the criteria adopted by the POSEIDON classification and compared to Bologna criteria, my question is, there still missed variable to be considered in the elaboration of this classification? The factor I am talking about is the risk factors for low ovarian response. Let me clarify my point. In the POSEIDON subgroup 3, imagine we have a patient less than 35 years with unexplained low ovarian response. I underline the word unexplained. And a same patient or another patient with the same age, but this time this ovarian response is explained by, is due to, for example, radio or chemo or therapy and many or whatever the risk factors. So I think that both patients, although they share the same subgroup, but in terms of prognosis, I don't think so. What do you think about this comment?
I really thank you for this question, because you focused on a very crucial point. Group 3 POSEIDON, and I remind you, are patients below 35 with low ovarian reserve, is the most heterogeneous group. Because what is not expected is not the poor ovarian response. What is not expected is that patient have lower follicles, lower ovarian reserve with respect to age. This is strange. And it could be related to different genetics, chemotherapy, previous surgery, endometriosis, idiopathic, autoimmune. So there are probably 10, 15 subcategories in group 3. So it is possible to find a group for any pathogenic category. We should have 25 POSEIDON groups, which is not obviously consistent with the good science and clinical practice. So the concept there is that probably the pathogenesis is different, but we can expect that given they are younger patients, probably they have a common euploidy rate and oocyte quality. So in this situation, the homogeneity is related to the general quality of the oocyte. Obviously, it's not perfectly true, because if some genetics are there or endometriosis is active, probably the quality will be affected by other factors. But at the least in terms of a euploidy rate, age is the most important predicting factor. So probably this patient are internally homogeneous for this aspect, euploidy rate. And so the target of a number of eggs is according to this the initial evaluation.
Thank you so much. I'm an IVF doctor, but also epidemiologist and biostatistician. So I try to bring those concepts to our field, reproductive medicine. I understand POSEIDON is a classification, a prognostic of the outcome, being delivery rate, cumulative delivery rate. When you define low prognosis, did you have a number in mind, an absolute difference or a risk difference? Because I can imagine that it is not the same having 5% less pregnancy in a 35-year-old than a 45-year-old or 40-year-old. So what was your mindset when you defined low prognosis? A number, a perception, or a risk factor? Thank you so much.
No, obviously, if I understood well, your question is, but first of all, I cannot see you because the light is very, where the question coming from? Hi, how are you?
Because we have
okay, so if I understood well, your question is, how can I say that that patient has a low prognosis or low chance to have a pregnancy and whatever? This is the question. Because the audio is also not perfect.
Sorry, no. My question is, this is a prognosis for the outcome, for delivery rate. So if you say it's low prognosis, there is a difference to a normal prognosis. So when you say this patient has a low prognosis, it means she's going to have a 5% lower pregnancy rate. She's going to have a risk ratio of 0.8. What was your mindset when you developed this great tool? You said any woman with a prognosis 5% less is low prognosis.
Okay, in everything in statistics is based on nomograms, is based on distribution analysis, having general population, and in this case we have a general IVF population. So what basically, because I mentioned this but very rapidly, but when you try to define prognosis, you need obviously a control population. In our case, studies had been performed in general IVF population divided in patient fitting with the POSEIDON criteria, in patients that we can consider normal prognosis patients because not fitting with the risk factor for lower prognosis. And obviously the expectation is set on the basis of a comparative analysis. So if you take non-POSEIDON patient as a whole, as an entire group, they have statistically significantly higher cumulative live birth rate compared with the 4 groups and 2 POSEIDON subgroups. And if you have a look to the differences among the POSEIDON group when you compare each other or subgroups, there is also difference. So at any given age, we have an expectation from statistical analysis of life and cumulative live birth rate, and in comparative analysis with the POSEIDON groups, this is significantly lower. If you want to have an idea of the numbers of the percentage, it is clearly published that you can see the cumulative life. 50%. Yes, there is even 50% difference when you consider the good prognosis patient and the worst POSEIDON patients. Yeah. Worst in terms of prognosis, obviously.
Okay. We can always try to improve the outcomes, but we can also find some surprise. For a personal cohort of 1,800 infertile women, for the women less than 35 years, I have 23% of women that have an AMH level less than 1 nanogram. It's I presented this in the RCOG Congress. For the first time in the literature, we find this. The second time, in June, Professor Human Fatimi find the same thing in the population of Dubai and the Arab Emirates. Is there some genetical problems or environmental problems? We have also, I consider that POSEIDON is a good tool for the democratization of IRT. We can, with the stratification and the calculator, improve a little bit the outcomes when we don't have time lapse, we don't have artificial intelligence like most countries in the world.
I have a question. Actually, I am very curious. If we exclude PCOS patient, young PCOS patient, what is the percentage of optimal responder in your everyday clinical practice undergo IVF? Because in a region where I am coming from, majority of our patients belong to the POSEIDON group 1 and 2 as a normal response. Actually, we have patients with less than 10 cells. So the focus of my question probably will be that in a recent future, we will have as a normal responder group 1 and 2, if you have the same experience. Thank you.
Well, considering group 1 and 2, it is a problem because you can overcome the problems that might cause you an unexpected suboptimal response by high doses of FSH or adding LH from the beginning of the stimulation empirically. So, for example, if you will treat a patient with 225 units of FSH or 300, you will overcome this hypo-response problem. So you might not see it. So in patient, for example, where you will only decide to give 150 units or less, you might see this situation. You might also overcome the situation by measuring polymorphisms. And you can overcome it by giving LH, recombinant LH to all the patients. And this is some of the practices in some of the places. So you might not see group 1 and 2 at all if you do all this in advance. But not everybody is doing that. And group 3 and 4, you will see, and this is about 10 to 15% of your population, depends if you have now a high number of advanced maternal age patients or not, but generally poor response or diminished ovarian reserve is about 10 to 50% of the general population, what you see.
So and I also thank you for this question because it's a crucial point. I think that PCOS is an important confounder for defining group 1 to the presence of PCOS, because I think that if you are clear diagnosis of PCOS according to Rotterdam or other classification criteria, they should be excluded, in my opinion, from POSEIDON classification, because obviously the risk of having less eggs with respect to the initial ovarian reserve is very high for iatrogenic reasons, because sometimes we start with very low. I think that the vast majority of the cases where the number of eggs is dramatically lower than expected in PCOS is because sometimes we start with too low doses, or is so we run the risk of to say that the patient is an hyper-responder, but is just a matter of matching of patients and protocols. So I think that hyper-responders, potentially hyper-responders, real PCOS patients are, in my opinion, to not be included in a POSEIDON classification.
Okay, so we have a last question, and what is the place of PGTA on the management of poor prognosis patients?
I think that among us, Filippo is the one that can give the best answer to this question. He's the most experienced. But in my opinion, the answer is very easy. Time to pregnancy. So let's go to the clinical practice. You have a patient 40 years of age, 5 antral follicles, and so you saw the incredible increase in the rate of aneuploidies you have year by year after 38, 39 years of age. If you have from a patient 3 frozen blastocysts, patient 40 years of age, it can take 1 year to transfer 3 blastocysts. And so after 6 months, 1 year, if the patient is not pregnant or had an abortion, she has to start again with an aneuploidy rate that increased at a 20% increase relative with respect to the previous year. So if you don't have a euploid blastocyst, it's better to know it soon and restart in 2 months with the second stimulation. I don't know if Filippo wants to add something.
Yes, I fully agree, and of course, and then one more thing in support of doing PGTA is the fact that PGTA is not done to improve the cumulative live birth rates per starter cycle, because either you do or not, the efficacy of the treatment is exactly the same. What you do, you improve the efficiency of the treatment. So it means, like Carlos said, you shorten the time to pregnancy, and especially you decrease the chance of miscarriage, and you decrease the possibility to have a pathological pregnancies. So if you decide with the patients that the patients wants to maximize her efficiency, or only with one single blastocyst, you should go for pre-implantation genetic testing.
So, yes, I think that people doing research on writing papers has the responsibility of what writes. But the responsibility of reading in the right way is also even more important. Let me tell you, I read a paper recently. It was a collaboration between the United States and China, if I remember well, on New England, very important paper. The conclusion was that PGTA is not useful. And everyone say, oh, it's New England, PGTA is not useful. But let me tell you, this paper has been performed in patients below 37 years of age, below 37 years of age, in general population, having as endpoint the cumulative, the live birth rate. Is the same, I said, let me test the efficacy in salicylic acid in preventing heart attack, treating patient below 30 years of age. It's the same. So, and for 5 years. So below 36 is not the population that requires PGTA, and the live birth rate is not the right endpoint. Wrong population, wrong endpoint, and they conclude that it's not useful. And everyone in the world says it's not useful, it's not useful.
Carlo, it's a very, very tough discussion. It's 10 years that I'm debating whether to do or not. Anybody has his opinion, then in his clinical practice, continue to do what he really thinks is the best for a patient. That's it.
Okay, it's time. We must close the session. Thank you and congratulations for the presentations. And now it's time to the coffee break.